Good morning, colleagues. I have no financial interest in this presentation. Most of what I will be presenting is from documented texts, some other people's presentations, and my experience so far. The aim of this presentation is, first of all, to give us the basis and then the principles of managing the complications that we have from trabeculectomy. So the topic we're taking today is trabeculectomy, its complications and its management. I'll first take the principles of trabeculectomy, sequence of events related to tissue repair after trabeculectomy, simple things that one can do to minimize having complications from trabeculectomy, its classification, and then I'll take the common complications. We know that there are so many of them, but I'll take the common ones and we'll talk on how to manage them. Now, we know that trabeculectomy is a gold standard for glaucoma surgeries. And basically, the aim in trabeculectomy is that we want to make an alternative pathway for the aqueous humor to drain, so that we're not dependent on the drainage through the trabecular meshwork or the uveoscleral outflow. So what eventually happens in trabeculectomy is that an alternative pathway occurs so that aqueous flows from the posterior chamber through the PI into the anterior chamber, then through the sclerostomy, and then it goes out into the subconjunctival space. So the aim in trabeculectomy is, after making that alternative pathway, you maintain that pathway so that it is patent for as long as possible. Now, in the past, what we used to do generally for trabeculectomy is, after a patient has been blocked, we do either a fornix-based conjunctival flap or a limbal-based conjunctival flap. Each of them has its own pros and cons. And then you apply an anti-metabolite to the scleral bed. After that, you do a superficial scleral flap. Usually, half to two-thirds thickness of the flap is lifted like this. Then a deep scleral then a deep scleral block is taken out. It's either taken out using a Vanna scissors or a punch, and eventually we do a PI. The scleral bed is closed to maintain that trap door, and then eventually the conjunctiva is closed. Usually the scleral bed is closed in such a way that it is not too tight. There's little egress of aqueous coming out to enable the subconjunctival drainage of the aqueous. But then there's a watertight conjunctival closure. There are a few modifications that we see now. Most people now use corneal traction sutures, though the superior rectus suture can still be used. Then a lot of people, instead of using the knife on the blade on the backpacker, they use the pocket knife, the crescent knife, to raise the superficial flap, and then continue with a deep scleral block with pre-placed releasable sutures. Eventually the sutures are closed and the conjunctiva is closed. Some people, depending on their experience, use 2 releasable sutures, 1 releasable suture. It depends on what the surgeon is comfortable with. Now, once trabeculectomy is done, there's a natural healing process that takes place in the body. There's release of plasma proteins and blood cells. This forms a fibronectin clot matrix. There's immigration and replication of macrophages, fibroblasts, new capillaries, fibroblast synthesis of collagen, glycosaminoglycans, and fibronectin. Eventually, there's formation of fibrovascular granular tissues, continued collagen synthesis, capillary resorption, and eventually there's this dense collagenous subconjunctival scar. So if nothing is done, all this process will take place, and then the trabeculectomy will scar. There'll be a subconjunctival scar, and then you will not have adequate drainage of the trabeculectomy, and it will not work. So there are risk factors that bring about this formation of scar. So whether it's fibroblast formation, whether it's the chemotactic factors, some of them are heightened in different individuals depending on the type of pigmentation. So we notice that for people that are from African descent, where you have more pigmentation, you have more tendency towards scar tissue formation. For patients who have had intense pre or post-operative inflammation, there's increased scar tissue formation. And then when there's blood beneath the conjunctiva, it also accelerates fibrosis. But apart from these external factors that can cause a trabeculectomy to fail, you have internal factors that could cause it to fail. These include inadequate opening into the anterior chamber, scleral remnants when the sclerotomy is being done, Descemet's membrane in the fistula, or a blockage of the internal ostium by prolapsed iris, vitreous, ciliary body. And so because of all these things that could cause a trabeculectomy to fail, there's things that are advised to be done to improve the trabeculectomy outcome. These include preoperative inflammatory steroids, discontinuation of myotics that were used 2 weeks pre-op, because this causes breakdown of the blood aqueous barrier. Treatment of post-operative inflammation, then intra-op minimization of manipulation of the conjunctiva, the xenons, the iris, or any tissue that is touched during the surgery. Adequate hemostasis, adequate iridectomy, and of course, we also have pharmacological agents that are used to improve the outcome of trabeculectomy. One of them is the corticosteroids, which is used, given just after the surgery, subconj injection, and then it's continued. I usually use steroids for as long as 2-3 months after surgery, but of course it has to be supervised steroid use. Then antimetabolites that are used intra-op include the 5-FU, the MMC, and in some cases people use 5-FU injections post-operatively. Recently, there have been some studies on the use of anti-VEGFs, though not generally used, but they are also advocated for use because they improve trabeculectomy outcome. And a very recent one is the amniotic membrane grafts that is expected to improve trabeculectomy outcome. Now, there are some simple changes that minimize trabeculectomy complications during surgery. First of them is careful selection of the patient that you're using, that you're operating on. For instance, the amount of precautions you take for a Caucasian will be different from those you take for an African. An African, somebody that's of African descent definitely must have antimetabolites use. And also depending on how young the person is, or if the person has tendency towards keloid formation, one will be thinking of using a higher concentration of antimetabolites. Usually, concentration for MMC is 0.1 to 0.5 milligram per mil. So whatever you use depends on the type of patients that you select. I generally use 0.4 milligram per mil. Also, while doing the trabeculectomy, you advisable to have a large treatment area. So once one is doing the conjunctival dissection, you should increase it posteriorly. The more posterior it is, the more posterior you're likely to have your bleb form. And it should be a wide area so that you can have a good diffuse bleb forming. Also, while managing the conjunctiva and other tissues, one has to be very careful. With the conjunctiva, you want to avoid using of tooth forceps so that you don't cause any buttonholing, which will give complications later. While making the scleral flap should be large, not too large, but then it should, at the sides, it should stop just before the limbus. At the central part, it should go at least 1 mm into the clear cornea. Proper use and irrigation of antimetabolites, the right concentration, antimetabolites to the date at which it was reconstituted and mixed should be taken note of so that an expired one is not used. Also, single scleral punch sclerotomy, very important, because you don't want to have jagged edges, and those jagged edges may predispose towards blockage. When closing, you should have a tight adjustable suture. This releasable suture should not be so strong, so tight that there's no ooze. So it should be tight, but then there should be provision for a little oozing of the aqueous so that you can have subconjunctival drainage of the aqueous. Also, with the conjunctival closure, there must be tight, watertight closure. And then, of course, after that, guided use of steroids. So this is a diagram showing the changes. Here, wide, large area treatments. When you're doing your dissection of the conjunctiva, extending backwards so that your bleb forms backward. Another thing you do so that the bleb doesn't overhang is that once you're putting your conjunctival sutures, you put the two at the sides and a mattress suture centrally. This limits the spread of the aqueous or the formation of the bleb forwards, not aqueous, of bleb formation forward. Also, other things that I've said, there should be a not too firm or tight releasable suture. Why the suture should be tight is you don't want it too loose so that you don't have overfiltration, and then the other things that I mentioned. Now, there are different types of bleb. By the time you look at your bleb, it gives you an idea whether the bleb, the trabeculectomy is functioning or it's failing. The first type of bleb you have is a diffuse polycystic bleb. This shows that there's transconjunctival flow and there's good filtration. You can also have a thin but diffuse, slightly avascular bleb. This also shows that there's good filtration. However, when you have a vascularized flat bleb, which has no microcystic spaces with engorged blood vessels, then it shows that the bleb is failing. Or in a case where you have an encapsulated bleb, where it is a highly elevated dome-shaped bleb without microcysts and then engorged blood vessels, this is a tenon-says, and it shows that it's a failing bleb. So here I have a picture of one of our patients who had bleb. This is just one day just after the bleb surgery. You can see here that there's a diffuse bleb, and then you have your releasable sutures, and this is air bubble just to make sure that the AC is well formed. I've used here the Indiana bleb classification. There are so many other classifications, but this is quite convenient here because it uses the height, the extent, the vascularity, and the Siedel's test to assess the bleb. Now, there are complications that you can have from trabeculectomy. Intraoperative complications, post-operative complications. The post-operative complications, like we know, are divided into early and late, using 6 weeks as a cutoff. Now, for the early complications, you can have buttonholing of the conjunctiva. Now, if this is noticed on the table, then it's advisable to make sure that that conjunctiva that is buttonholed is closed up. So you suture it and make sure that it's closed so that your bleb forms properly. Also, Intraoperatively, there can be a scleral flap tear. If you can repair it, you go ahead and use that same scleral flap that has torn off and repair it. It also depends on how much tear, whether it's the whole thing that has come off or just a section of the scleral flap is off. However, if you cannot repair it with the tissue that came off, then you can take a donor tissue either from the other eye or even from the index eye that you're using. Usually, most of our patients present one eye already blind and the second eye getting blind from glaucoma. So it's very convenient to take a donor sclera from the other eye, which most likely is blind, and use it. But where there's no access to donor scleral flap from that patient, then pericardium can be used to close up the scleral flap tear. Now, also intraoperatively, you can have lens injury. The common cases where you have lens injury is when a surgeon tries to fish for the iris while doing peripheral iridectomy and inadvertently damages the lens or the lens zonules while trying to fish for that. And most of the time I tell people, once you're doing surgery, immediately you do your sclerotomy either with a punch or with a vinyl scissors. The iris pops out. That is the correct time at which to do a PI. Don't wait until the iris goes back inside and then you have to fish for it. If you have to fish for it, then most likely you have some lens injury. Also, intraoperatively, patients could have hemorrhage. If a hyphema occurs on the table, then it is wise to clear it. But if it's on the sclera, then hemostasis must be maintained, because if there's continuous bleeding and there's bleeding under the conjunctiva so that you have a subconch hemorrhage, this is likely to promote fibrosis and help your bleb to fail earlier. I'll talk about choroidal effusion as we go on, but it's also good to know that even intraoperatively, choroidal effusion can occur because surgery itself is one of the risk factors for choroidal effusion. Usually the one that occurs intra-op is asymptomatic and it clears spontaneously without any intervention. So now we'll talk about the post-operative complications. Now, the very common post-operative complication we see is shallow anterior chamber. Now, shallow anterior chamber can be associated with a low intraocular pressure, or it can be associated with a high intraocular pressure. When it comes with low intraocular pressure, it indicates that there's overfiltration. Now, overfiltration can be due to scleral flap leakage. If there's scleral flap leakage, there will be a well-formed bleb, the CDELs will be negative. But then if it is due to a bleb leak from a buttonhole that was not closed, was not noticed and closed during the surgery, or if during conjunctival closure, it was not watertight closed, then you will notice that there will be a flat bleb and there will be a positive CDELs test. In this case, most of the time, if it's just a bleb leak from a buttonhole, with conservative management, it resolves in about 5-7 days. So conservative management would now include things like dilating the eye, reducing the amount of steroids you're using, aqueous suppressants, and then you monitor the patient. But as you observe the patient, pressure may reduce further and you start noticing folds in Descemet's membrane. And then also depending on the amount of shallowness of the anterior chamber, whether there's corneal lenticular touch, then more aggressive management is instituted. When there's corneolenticular touch, there's likely to be corneal edema. Other things that could be done for the patient is pressure padding, and you could use a gauze and you pad. Usually I pad during the waking hours, and well, during the night hours compulsorily, during the waking hours in between, because patient has to keep on putting eye drops, you pad for some days and you observe and you see. But then because of the challenges of padding the eye with gauze and all that, if you have a large diameter bandage contact lens, this is ideal because it covers the bleb site and yet the patient can see and move around. You can also use a Simmons shell if it's available. But if all this have been done and you notice that there's no closure, and also depending on how deep the AC is, then one may have to go back to the theater and resuture either the conjunctiva or sclera, depending on which one is causing the overfiltration. The AC too will have to be reformed either with air or with SF6. Now, in some cases, there may be choroidal effusion, and when one examines the patient, you may notice that there's some kissing choroids, which will be very obvious on the fundal exam and with the BIO, and then with the B scan, you can confirm that. Now, if you have choroidal effusion, a lot of it resolves spontaneously in 2 weeks. But if it persists and then the patient is beginning to have hypotony is worsening, then it would be right for one to go and drain the choroidal effusion. Now, shallow anterior chamber could also present with high intraocular pressure. Where there's high intraocular pressure, one has to determine the cause of the high intraocular pressure. In both of them, usually the bleb is flat and Siedel's tests are negative. But in malignant glaucoma or ciliary block, or what you call the misdirection of the aqueous, the catch there is to check the shallowness of the anterior chamber. In this case, both the peripheral and the axial anterior chamber is shallow. And in such a case, what you do for these patients is that you give them mydriatrix, you give them mannitol to shrink the vitreous gel, and then because there's a patent iridectomy, you use an ND-YAG through the patent iridectomy to disrupt the anterior hyaloid phase. If the patient had trabeculectomy with a cataract surgery, then a capsulotomy has to be done so that through the capsulotomy, you can now use the ND-YAG laser to disrupt the anterior hyaloid phase. And then in some cases, you may have to do a pars plana vitrectomy. However, if you examine the anterior chamber and you notice that the shallowness is only peripherally and the central is deep, and you also notice that there's no patent iridectomy, so it's more likely due to a pupil block. In this case, we do use an ND-YAG laser to make the pre-existing iridectomy patent. Patient is also placed on steroids, aqueous suppressants, and myotics. And usually with these treatments, the patient improves. Now, this is a picture of a positive Siedel's test. You can see here that the fluorescein strip is being dispersed as aqueous is coming out from the leak. And this is a picture showing choroidal detachment. And you can see here with the kissing choroids showing. This is one of our patients who had a bleb leak. after surgery. You can see here that he has a diffuse, well-formed bleb, but there was a leak. And so we put a BCL on him. The BCL just goes to where the leak was. The larger the diameter of the BCL, the better it is. So if you have a large diameter BCL, 13 millimeter and above, it applies more pressure to the leaking area. Now, sometimes a patient can come in with an elevated intraocular pressure, and yet the AC is deep. Usually, in such cases, it heralds a failing bleb. And so one has to examine to see, is it a vascularized bleb or is it an encapsulated bleb? So here you have to do slit lamp examination, BIO, examine the patient, and then of course gonioscopy that will tell you the cause of the vascularization or the encapsulation. Now, when a bleb is vascularized, usually it is a flat bleb with a lot of vascularization, no microcysts. And this occurs in 6.9 to 36% of patients. Now, it is caused by either the scleral suture was too tight, and so there's some scarring occurring along the scleral bed, or it's more interior, so that there's a blockage either at the sclerotomy or even in the internal ostium. At the sclerotomy, it could be blockage by vitreous, blood, uveal tissue, or in the internal ostium by a thin membrane. Now, for all this, the key is early detection and aggressive intervention, because once you intervene on time and you do the right thing, you can save your bleb. Here, what we do is intensify your steroids and then digital massage. Now, the digital massage helps to dislodge whatever was blocking the ostium. So whether it was vitreous, blood, or whatever, it helps to dislodge. And what I usually do here is that you tell the patient to look up, and then you apply pressure inferiorly, 180 degrees on the eyelid, 180 degrees away from the bleb, and then you apply firm pressure for a few seconds. And as you apply that pressure and you look at the bleb, you'll see that the bleb begins to form and opens up. You can also teach a patient to do this at home, and the patient does it morning, afternoon, night, and then you observe what happens. Other things that could be done, especially if it is a tight suture at the scleral flap, is to release the releasable suture. And this, once again, stresses the importance of putting a releasable suture when you do a trabeculectomy. So here you release the releasable suture, and you will also see the bleb forming properly. And where you can't release, then you can use laser suture lysis to lyse the suture and help the bleb to form. Also, you can also use ND-YAG laser to disrupt the tissues that are within the internal ostium. For this, you have to do it with gonioscopy. Now, if a patient has, you examine the patient and you see an encapsulated, erased bleb. So in comparison with the vascularized is there's a flat bleb. But in the encapsulated, it is raised, is dome-shaped, but is highly vascularized with no microcysts. And with gonioscopy, you see that there's a patent sclerostomy. In this case, it means that the problem is at the subconjunctival episcleral level. And here you will see that there's a ring of steel. Now, this usually happens before 2 months after trabeculectomy. And for these patients, initially, of course, you do the conservative management, steroids, compression, if you can, you have releasable suture, you release and all that. But eventually, you will have to do a needling of the bleb. And some people also give subconj injections of 5-fluorouracil, which helps the to combat the failure. So here I have a diagram of a vascularized bleb. You can see here is a flat bleb, and you can see highly vascularized. Here, most likely the problem is with the ostium, the scleral bed, tight sutures, so you look out for those and do gonioscopy. Here we see a patient with an encapsulated bleb, and this around it is what we call the ring of steel. So you can see that here there's a bleb is elevated, and beyond that you have vascularized conjunctiva. And usually for this type of patients, you need to do more aggressive treatment with your 5-FU injections or needling of the bleb. Now, bleb leak. I mentioned a little bit about it earlier, but because it's a common thing that occurs, I felt I should deal on it more detailing. Now, causes, it can be due to the use of antimetabolites, which were probably not completely irrigated off, or the date of reconstitution expired, MMC or whatever. But with mitomycin C, it has been noticed that there's an increased tendency towards a bleb leak because it causes very thin avascular blebs. Other predisposing factors to a bleb leak include repeated conjunctival injections, pre-operative, post-operative, and then of course poor wound closure. Now, complications that can occur from bleb leak include corneal decompensation, peripheral anterior synechia, choroidal hemorrhage, hypotonic maculopathy. And that's why it's important to look out for it. Some patients may not have symptoms, but a few may tell you that they notice tearing at night, sometimes the wetting of their pillow. Those that see may tell you, but a lot do not notice that. But when a patient comes in, pressure is low, there's an avascular cystic bleb, there's a shallow anterior chamber, and there may be choroidal detachment. When you examine, there's a negative. It depends actually at what stage the patient comes in. Some may come in and initial time there's a negative CDELS test, but with time, as the bleb leak increases, it becomes a sweating bleb, then with hole formation, it becomes a positive CDELS test. Now, it's very important that we manage a bleb leak on time and manage appropriately, because we should remember that a trabeculectomy is a fistula that opens into the eye. So it means these patients are predisposed to infections, blebitis, and worse, endophthalmitis. So once a patient comes in early, you discontinue the steroids. You can put them on non-steroidal anti-inflammatory. You also continue the antibiotics that you're using, a more potent one. But in addition to that, I always add gentamicin eye drops, because gentamicin helps fibrosis of the conjunctiva and helps healing, and so helps to close whatever hole had formed, especially if it is not a very large hole that is leaking. Pressure pad, wide diameter bandage, contact lens, aqueous suppressants. Usually the bleb leak will resolve in a few days, especially if it was not late after surgery. However, if the wound, the leak is large, then you have to go back to the theater and close that leakage. It's also good to note here that cyanoacrylate glue has not been reported to be very beneficial in these cases. Now, if a patient comes late and it is just a sweating leak that you notice, then autologous blood injection can be used, and also compression sutures. But once it's a full thickness hole and the Seidels test is positive and it's just draining, then you have to go back and abscise that conjunctiva and then have a conjunctiva advancement. So what I do is that the bleb that has the hole inside, I abscise that, take it out completely, and then advance the conjunctiva forward and then suture it. However, sometimes you may not have enough conjunctiva to advance like that. So you can do a conjunctiva patch autograft or a scleral grafts for these patients. It's also good to know that once a patient has had a leak, there's a likelihood that there will be a repeat leak. So even after you have done the surgery, a repeat surgery, or you've done conservative management and it has resolved, you continue to monitor the patients to manage. Now, another complication that you have is blebitis, infections, blebitis, endophthalmitis. Risk factors include blepharitis, long-term steroid or antibiotic use. Why this is very important is because you put patients on steroids. Usually, I said I put them for up to 3 months and all. And your patients may not come back for follow-up, and he continues using the steroids. So after trabeculectomy, we'll have to be very clear to the patients as to when we want them to use or not to use medications. So long-term topical antibiotics or steroid use can predispose to infections. Then pathogens include H. influenza, streptococcus, staphylococcus species. Now, the virulence of the organism determines how the patient presents. Now, when a patient has blebitis, there is no vitreous involvement. So there's an infection of the bleb, but it's mild and vitreous is clear. Now, the patient comes with a white, thin avascular bleb, no anterior uveitis, normal red reflex. In such a case, you do a conjunctival swab for MCS. Please, under no condition should you aspirate sample from the bleb. One, because as you're aspirating from the bleb, you're creating a bottle hole and you're compromising your trabeculectomy. And as you're creating that, you're introducing more infections into the bleb, which could spread into the eye and cause an endophthalmitis. So with the blebitis, you give antibiotics to cover, depending. We usually give vancomycin, cefuroxime hourly, and we monitor the patients with systemic antibiotics. But when a patient has endophthalmitis, here there's vitreous involvement, so there's a rapid worsening of vision with pains, with redness. And when you examine, there's a milky white bleb with pus. When it's severe, you have severe anterior uveitis, sometimes with hypopium, vitritis, and then an impaired red reflex. For such a patient, a vitreous tap should be done. A vitreous tap, in addition to AC tap, and this should be sent for MCS. And you treat just like you treat any endophthalmitis. So you start empirical antibiotics, and then when the investigation results come out, you change to the ones the patient is, the organisms are sensitive to. Here too, you give the patient intravitreal antibiotics, subconjunctival antibiotics, topical systemic antibiotics, and depending on how bad it is or how virulent the organisms are, a pars plana vitrectomy must be done. But it's also good to note here that endophthalmitis from trabeculectomy is more serious, usually more rapidly progressing than that from maybe cataract surgery or any other surgery. So once a patient presents with signs of endophthalmitis, then you must start treatment and treat aggressively. This picture shows a patient that has blebitis. So you can see here there's inflammation of the bleb, but the anterior chamber is clear, no signs of uveitis. Unlike a patient that's had endophthalmitis, apart from the bleb being affected, there's some vitritis, uveitis, vitritis, sometimes hypopyon. Okay, so in summary, what I have said is a patient comes to you after trabeculectomy. The first thing you do is check the intraocular pressure. Now, the intraocular pressure will help you to classify the patient. If the intraocular pressure is low, then you check the AC depth. Now, AC depth can be shallow or it can be deep. If the AC depth is shallow, you do a Seidels test. A positive Seidels test occurs in a leaking bleb, and the leak can be due to conjunctival, so that's usually the buttonholing or posturing of the conjunctiva, or it can be due to from the sclera, which was not well closed, and you see that. Now, when the Seidels test is negative, then most likely there's some form of choroidal effusion, and you check that. Now, if AC is deep, then you watch for signs of hypotonic maculopathy. Now, if you check the intraocular pressure, IOP is high, you check the AC depth, and the AC is shallow, you want to check the central depth. Now, if the central depth is equal both peripherally and is equal both peripherally and centrally, then you check the symptoms. If patient hardly has any symptoms at all, then it's most likely aqueous misdirection. But if there's nausea, vomiting, and the patient is having rapid reduction in vision, then there's likely to be suprachoroidal hemorrhage. But if the AC is deeper centrally and shallow peripherally, then it's likely to be pupillary block. Also, high IOP AC is deep, and you do gonioscopy, then you check whether there's a patent osteum or a blocked osteum with your gonioscopy. If the osteum is blocked, then it's a vascularized bleb. But if it's patent, then you'll be thinking of an encapsulated bleb. Now, there are other complications that can occur after trabeculectomy. One of them is a cataract formation or after trabeculectomy. After trabeculectomy, there's an increased incidence of cataract formation. But it's good to note that usually it doesn't just form like that, it comes with complications. So most likely there'll be some posterior synechia, and anterior chamber is likely to be shallow, hazy cornea, and all that. And also there's a challenge for cataract surgery here because it depends on the site of the initial trabeculectomy. Usually when I do a trabeculectomy, I do a superinasal approach so that a lot of the temporal aspect is left in case you have to come back and do a cataract surgery. I've had a patient who had trabeculectomy and it was done temporally. So it was very difficult to do a temporal approach for the cataract surgery. Eventually, I had to do a superior approach, but you can imagine how difficult that was. Also, apart from doing a temporal approach where you can, phacoemulsification can be done for such patients, but it's also worthy of note that cataract surgery after trabeculectomy seems to compromise the bleb integrity. So in this first diagram, we see a patient that came back with cataract, but it's a complicated cataract because there's a 360-degree posterior synechia. So that means eventually we'll have to do synechulisis, we'll have to use iris hooks to open up the iris to be able to do a cataract extraction. The second patient here had a bleb and came with a cataract, and we did a phaco for him. You can see the margins of the capsuloresis. So we did a phaco for him, and he's quite okay. Another complication that can occur with trabeculectomy is delayed suprachoroidal hemorrhage. Now, this is usually associated with severe symptoms of pain, nausea, and marked reduction of vision. IOP is very high, and usually we're told to wait for about 2 weeks for the clots to lyse, and then after that we drain. And usually the draining is sclerostomy is made, well, depending on, first of all, you have to do a B scan, you have to do an examination of the patient so you have an idea of where the hemorrhage is, and that will determine where you do the site at which you do your drainage. And so usually the drainage is done and it's posterior to the limbus, an incision is made, and then the lysed blood is drained out. Another complication that occurs is an overhanging bleb. Overhanging bleb, like I said earlier, can be prevented based on how you do your conjunctival suturing. So usually if you have a mattress suture put centrally, it limits that. And also if you have a limbal-based conjunctival flap, you're not likely to have an overhanging bleb. And also when you're doing your trabeculectomy, you dissect posteriorly, you place your anti-metabolite sponge, MMC, as posteriorly so that your aqueous drains posteriorly, and so you have a bleb forming posteriorly. But then if a patient presents with an overhanging bleb, it's usually cosmetically unsightly, it is irritating, patient keeps on complaining of a foreign body irritation, and like in this case, it begins to affect the visual axis. And once a patient has this, there's difficulty with closure of the eyelid, with proper closure of the eyelid, there's a tendency towards exposure keratopathy. Initial treatment for this patient is to give them lubricants so that you maintain the integrity of the cornea. However, subsequently, you have to upsize the overhanging bleb, then advance the conjunctiva, and then close up the bleb. Of recent, I've hardly seen people with overhanging blebs. This is one of our patients that came in some years back, and then we did abscission and then advancement of the bleb, and the patient is fine. Okay, so I think that's basically all I have for us. Thank you very much for listening. So I'll take questions. Hello? Okay, where are they? Okay, in the Q&A. Okay, so the first question I had here is I noticed that you use air to reform the anterior chamber. What's its advantage over balanced BSS, considering that the air bubble can escape and block the ostium, giving rise to a malignant? How will you manage it? Well, it depends on what you are comfortable with. A lot of people use balanced salts. In fact, apart from the BSS, some people even go as much as using viscoelastic to close. But usually when you use air to close, it's just a little air, and by the time you open up the eye the next day, it has already absorbed, so it doesn't stay long in the eye, and before you know it is absorbed. It doesn't usually give challenges. But if it moves behind, which it's a rare thing and shouldn't usually happen, then don't forget that you have a provision of using the ND to break the anterior hyaloid face. And if you do that, the air bubble comes up and it gets absorbed. Okay, it said, would you like to shed more light on autologous blood injection in bleb leakage management? Okay, number one, I want to say that I haven't used it before, but then it said that it can be used. Now, what they say happens with autologous blood injection, during the presentation, you heard me talk about blood under the conjunctiva, that when you have blood under the conjunctiva, it hinders fibrosis, it hinders healing. Sorry, it increases healing and makes healing. So one of the things you want to do when you're doing trabeculectomy is that you don't want to leave blood under the conjunctiva as much as possible. So when you have a leaking bleb, what you want to do now is that you want that bleb to heal. And so you can use blood to encourage healing, to encourage fibrosis. And with that autologous blood being injected, it helps the bleb to seal up. Here it says, we agree the teaching is up to 12 weeks post-op topical steroids. How do you manage cases of steroid responders? Well, what we do with steroid responders is, like I mentioned before, I use a lot of NSAIDs. So if I notice that immediately you started giving the patient, you've done surgery, trabeculectomy for the patient, first day post-op, usually pressure should be from 6 to about 12. If you have intraocular pressure that is greater than 15, then of course you should be thinking that that bleb is failed. If you have pressure that is less than 6, then it's hypotony and it's not good. Now, so you have seen that the pressure is about 6 to 12. Usually with healing, there's a slight buildup of intraocular pressure. But if you notice that there's rapid buildup of intraocular pressure and you're suspecting the steroids, then you can discontinue the patient from the steroids and use NSAIDs to manage the patient as anti-inflammatory substance. Okay, it looks as if there are no more questions. Oh, there are more now. Okay. Okay. Okay, the next question says, what is the difference between a cystic bleb and encapsulated bleb? Well, when you're talking about an encapsulated bleb, what you're more interested here is that there is a dome-shaped appearance of the bleb. And then there's that ring of steel that shows that there's a subconjunctival fibrosis. So even though the inner osteums are patent and aqueous is draining into the subconjunctival space. It cannot go beyond that because of the ring of steel. And when you have that, type, then you have to be, it's the type that you have to go back and do needling. So it's not just conservative management that deals with an encapsulated bleb. And also don't forget that an encapsulated bleb is also called a Tenon's cyst. So based on your question, there's really no big difference between a cystic bleb or an encapsulated bleb. The important thing when you see a bleb that seems to be failing is do a gonioscopy. Both of them will appear with engorged blood vessels. A vascularized bleb is flat with engorged blood vessels. A cystic or encapsulated bleb is elevated with engorged blood vessels. Now, when you do your gonioscopy, you will now be able to differentiate the cause. In the encapsulated one, your sclerostomy is patent and is okay, so there's no blockage. But in your vascularized bleb, there's a blockage. Okay. Then the other one, what do you do in a bleb advancement, and is there advantage over a normal bleb? You don't, well, when you say bleb advancement, you only do bleb advancement when there's a complication. So you have a complication with that bleb. Either the bleb is leaking or the bleb is overhanging. What you want in a bleb is that you want a uniform diffuse bleb, elevated, not too elevated, not too avascular, but is draining. So if your bleb is leaking, then, and all the other conservative measures are not working, then that's when you do a bleb advancement. Or if you have an overhanging bleb, then you can do a bleb advancement. So a bleb advancement is a treatment for a complicated bleb. Okay. Then, okay, yes, triangular and rectangular scleral flap. From the literature, there's no difference in the outcome. If you notice in eye center here, some of our surgeons use triangular, I use a rectangular flap, but from literature, there's no difference between them. But the reason why I prefer to use a rectangular flap is that it gives me more leeway in my suture application. So at one edge, I put a permanent suture, on the other edge, I put a releasable suture. It's easier for me to manage, so that if I remove one releasable suture, I know one permanent suture is in. But in terms of triangular and rectangular, they have the same outcome. Okay. In late bleb leak, is there room for amniotic membrane graft? Yes, there is. I think I mentioned it in the lecture. Okay. Then during management of overhanging bleb with abscission and advancement, does one need to do a more posterior dissection of the conjunctiva? Okay, see, I think maybe the issue here is I didn't go into details of each of. When I say advancement of a bleb, definitely you have to dissect to be able to bring it forward, because the overhanging bleb that you have cut off, once you remove that, there's a defect. So you now have to dissect and then bring it forward to be able to suture. So it's all part of the technique of doing the surgery. It looks like I've answered anything. Okay. Is needling not a risk for bleb leak? Well, you have to decide what actually you are doing. Here, it's easier for you to manage a bleb leak than for you to manage an encapsulated failing bleb. So for you to be doing needling, it means the bleb is already failing. So I think you have to weigh what is more important. I think what would be more important is you want this bleb to function. And then when you're through with the needling, you close up the conjunctival that was opened up for you to be able to do the needling. So if you do the surgery properly, you can take care of the needling and also the likelihood of a bleb leak. Okay. It looks like those are all the questions, right? Okay. All right, so are we expecting more questions? Okay. Finally, before I go, I would like Dr. Iheanacho to make a comment. I think she may want to say something about the BSS and the air bubble in okay, she's not online. Okay, so how did she send it? Oh, she left. Okay, all right. So thank you very much for listening to the lecture.